Now to Dr. Ghulam Ali for the final talk on setting up myopia practice clinic.
Good afternoon. This is my last talk of this instruction course. Setting up a myopia management practice differentiate your brand from the others in your city. Inversely, not offering a myopia management could damage your practice as patient may hear about myopia management from other sources and question why it was not offered to them by you. Uh, for good myopia management practice, you should have some protocol for the myopia patient, like good history taking, visual acuity and near distance vision measurement, refraction, binocular vision and accommodation assessment, and slit lamp examination, fundus examination, and IOP measurement too. Measuring axial length every 6 months to 12 months is recommended. It's worth considering retinal photography, wide field retinal photography, and OCT as baseline or screening. We should perform topography on indication and when fitting orthokeratology as mentioned by Dr. Chavan. Communication, the myopia management message is very important to the parent of the myopic child. You should discuss the risk factor for myopia onset and progression with the parents. You explain the goal of myopia management, explain the myopia risk, correction and management to the child parents, and explain the treatment option clearly, and you should take an informed consent. Equipment required for myopia management are like showed by Dr. Chavan, autoref, retinoscope, trial set, non-contact tonometer, optical biometer, topography, IDO or wide field fundus camera, and other equipment required for detailed eye examination. Staff training is as important as other thing in myopia management. So maximizing the talent of your team will help you to build excellent myopia management practice. Training your staff on the latest advance in and rationale for myopic management and associated diagnostic testing may help to position you as a leading practitioner in myopia management, answer questions the patients or their families may have, perform certain diagnostic testing, communicate the benefit of myopia management to your patients. And you should design the myopia marketing campaign also. You define your goals, choose an audience you want to target, choose the social media platform, define your message clearly, allocate budget and the timeline, and monitor your success or your leads accordingly. And follow-up schedule should cleared to your staff. For glasses, adaptation and compliance are likely to be less of an issue with glasses, making it safe for the first follow-up to occur at 1 month. In cases of the contact lenses, follow-up within the first week and again at 1 month help to monitor visual adaptation and handling and safety of the contact lenses. For orthokeratology, monitor compliance and safety vision and corneal topography outcomes after one night within 1 week and then 1 month and 3 months. For atropine users, follow up to ensure compliance, tolerance, and any impact of side effects within 1 week and 3 months. The purpose of the initial appointment is only to assess the adaptation, compliance, and suitability of the treatment and not their effect on the myopia progression. Experts recommend tracking success of myopia control efficacy every 12 months to account for variation in myopia progression. Tracking success in myopia management from the refraction. These are the some data of average eye per eye refraction. Age less than 9 years, minus 1 diopter. Age 9 to 11 years, minus 0.75 diopter. Age 12 to 16 years, minus 0.5 diopters. Any treatment you started, orthokeratology, atropine, if they are succeed to halt below this data, that is a good treatment. Tracking success in myopia management from axial length. In hemetropic eye, less than 10 years, axial length grow by 0.1 to 0.2 millimeter per year. In hemetropic eye, less than 11 to 16 years, 0.1 millimeter per year. In myopes, less than 10 years of the age, if untreated, myopia progression is typically greater than 0.3 millimeter per year, then the optimal outcome would be limit annual progression to less than this, since hemetropes of the same age progress at the rate of 0.1 to 0.2 millimeter per year. Slowing progression to this rate is outstanding results. Ideal outcome for preteen and adolescent myope include reducing their axial elongation to less than the untreated average of 0.2 millimeter per year. Slowing to less than 0.1 millimeter per year is an outstanding result. Thanks. Any question from Dr. Sanjeev, Mr. Chavan, Dr. Ron, Dr. Kavita? Yes, sir. Not working.
They sound contradictory, but actually both of them could work in tandem. So, oh. Yeah, so I was saying that they sound contradictory, they look contradictory, logically they are contradictory, but they work in tandem because violet is everywhere, it's out in the sunshine, and red is something that has been experimentally discovered to help. And the mechanism of action lies at different levels in both the therapies. So I think both of them are important, and red light therapy is also going to get its proper place very soon now in clinical practices. Uh, the blue blocking glasses are good for computer wear because you want to increase your contrast, you wear them. But they cut off the violet light. All glasses will cut off ultraviolet and violet light, and violet light is important. So, what I would suggest would be an amber shade, which at least permits some of the violet light to get through. So, that would be my answer. If anything more to add.
Yeah, blue cut lens is, it's just a marketing gimmick. It doesn't work. There are a lot of papers they have tested, doesn't work, but it works for optician, and you know they can make a lot of money out of that. Especially on the laptop and computers and everything. But for children, it is no, sir. We are talking about myopia control, so one answer is no, no for children's, no. Correct. No, no. You want even that uh, UV light is important for the eye. It is just modifying the 20 microns of the corneal epithelium. So otherwise it's not, and it is reversible. The moment you stop it within 3 months, the cornea will come back to its original shape. So, huh, correct. So these lenses are specially designed for overnight wear. FDA approval for overnight wear. What does that mean? Is if you put any other contact lens less than 100 dk, actually less than 80 dk, it will cause a corneal swelling. So there was a very famous paper by Brian Holden. So in normal closed eye situation, whatever the corneal edema happens, If you use anything more than 84 DK contact lens, it will be the same as a normal eye. So it is approved for closed eye situation. So no problem, it is safe. This is to be worn during night only, but if you are sleeping in the daytime, you can wear. Like most of the patients, in reality, sometimes they forget to wear the lenses in the night, and then by the afternoon, their vision starts dropping down, and they have some important meeting to go, or they have to go, watch movie or party. Then what I ask them is, it's like charging your mobile phone. You charge your eyes. So put the contact lenses, close your eye for 2 hours. Again, you get additional 5-6 hours of holding time. So design of that reverse geometry lens is causing that peripheral defocus, sir. So that's the principle, no? So in the center, they can see sharp and clear. The foveal vision is sharp and clear. Whatever is happening at the peripheral retina, patient is not aware of, but the brain is aware of what is happening. Huh? Huh? Yeah, in the night you are reshaping the cornea, so you are getting that cornea ready for the light to be in the daylight. That happens. So in the night it will reshape. You don't need to see or have any light in the eye, no, in the night. When in the wake up situation, when the light penetrates, it will divide. Central light will be on the fovea where they can see sharp and clear, and the peripheral retina will get at myopic defocus. That's how it works. IPD is most important.
IPT is very important. And the other thing is that the pentoscopic slant should be 0 degrees. And the frame should be moderately large. It should not be a very small frame. Otherwise, you will lose the advantage of it.
That is what the company says. But the IPD is more important for fitting any kind of this type of lenses. Yeah. Most of the companies, I think, they fit for you. You have to
You have to send the data to them, and they'll fit it for you and send it back.
So you send a frame and the IPD and the power. They will make the lenses. They will fit into your frame and send it back to you. Most of the companies. Huh? Bifocal. Yeah, one more time. Yeah.
It has been shown that adding a 3 prism diopter prism has an effect on accommodative lag, otherwise it's not. Yeah. Whole day, yeah. Test results have shown, studies have shown no results.
It see studies the atom study was from 6 to 12 years, but now in after lamp they are studied it till 12 to 15 years, and routinely even up to 15-year children are prescribed atropine eye drops, and they do work. They will work.
About to start, yeah.